We're going to get started. It's a great pleasure to introduce today's speaker. And today also happens to be our speaker's birthday. So when you clap for her, make sure you do it with passion. And also, we also have the honor of also having her mother, Mical Raz, in our audience as well. So it's such a great pleasure in a variety of ways. But most of all, Dr. Mical Raz is the Charles and Dale Phelps Professor in Public Policy and Health at University of Rochester. She also has been a hospitalist and in our medicine unit since 2019. And she completed her medical training at Tel Aviv University, from where she also received a PhD in history of medicine. She completed her medicine residency in internal medicine at Yale New Haven Hospital in 2015. And then she did the prestigious Robert Wood Johnson Clinical Scholar Fellowship Program, focusing on policy and university at University of Pennsylvania. And after that, she joined our faculty at University of Rochester Medical Center. And she is the author of the book, which I've been reading recently, The Lobotomy Letters, The Making of American Psychosurgery, which was awarded the Pressman Burroughs Wellcome Career Development Award. Her second book, also with great reviews, What's Wrong with the Poor, Race, Psychiatry, and the War on Poverty, which was also the 2015 Choice Outstanding Academic Title Award. Her most recent book, Abusive Policies, How the American Child Welfare System Lost Its Way, was published in late 2020. And today's grand round will be at least partially based on that book. And it is such a treat. I first met her through a discussion about the George Washington Corner Society that she oversees in Rochester, because she was inviting a psychiatry speaker. And while we were conversing about how important it is that we collaborate as a department for this wonderful history of medicine society, I was so struck by her brilliance more than anything. And it was a great pleasure for me to invite her to this grand round to give today's talk. So please welcome Dr. Raz.
Thank you so much. Thank you for this very generous introduction. Not at all embarrassing. And I'm really happy to be here today and speak with you all. I see some of you on consults and in the emergency room where I often work as the admitting hospitalist, and your med psych work. And it's really kind of an honor to be able to talk to practitioners and researchers in grand rounds. I'm going to talk about child abuse or child welfare, but I think it's also kind of speaks to bigger questions of what happens when you medicalize or even more so psychologize social problems. And I think you guys probably have this experience that you're being called upon to give answers or to give solutions for real problems that maybe sometimes psychiatry doesn't have the tools to answer them. And part of the story is what happens when you try to psychiatrize or psychologize social problems. So I'm just going to go through my slides. I don't have any conflicts or anything to declare. We are learning objectives you probably got on your email. Okay. And this is, okay. And as Dr. Lee generously stated, some of this work is from my newest book, which came out in 2020, which is a history of child abuse policies. And my newest work now looks at the Adoption and Safe Families Act, which I'm really excited about, thinking about how, in this day and age, thinking about adoption in the post-obs period. But I'm going to start today thinking about child abuse investigations. And experiencing a child abuse investigation, you might be surprised. It's just almost an everyday experience. 1 out of every 3 children will be a subject of child abuse investigation before the age of 13 if we assume constant level of risk, if nothing changes. Amongst Black children, we're looking at more than half Black children in this country will be the subjects of a CPS investigation. 1 in 100 children will experience involuntary termination of their parents' right to parent them, but also of the child's right to have parents. what researchers have termed involuntary or state-induced parental loss, or sometimes even called legal orphans. You no longer have parents because of a separation. Sometimes that results in adoption, but sometimes it doesn't. These numbers are staggering. But is there an actual epidemic of terrible child abuse going on? In fact, child abuse is terrible. This is not a support of that. But we do know that there has been a steady decline in child abuse cases over the past decade. And in fact, the majority of substantiated child maltreatment cases deal with neglect. Over the past half century, the child welfare system has been transformed into one that investigates and regulates behavior, and all too often punishes parents for their poverty while prioritizing investigations over the provision of services. Since the 1970s, we've seen a vast shift in what we consider to be child abuse and neglect, and a concurrent expansion in coercive interventions into families by the child welfare system, which critics, as myself, refer to as a family regulation system or the family policing system. Parents are afforded less freedom to make decisions for their children, such as allowing them to play unsupervised in a playground while mom works, or stay in the car while parent runs a quick errand. And these are all examples that people have gotten into significant legal and child welfare entanglements for these choices, even though we actually know that society is safer with lower rates of violent crime. Parenting has been transformed into a constant role of vigilance and supervision, divorced from actual risks, which further disadvantages people who are low income, particularly mothers, who need to balance work, childcare, and these heightened expectations of constant supervision in a tragic situation in which our society actually fails to offer any standards of support for parents, for mothers particularly, including maternity leave, sick leave, or subsidized high-quality childcare. So how do we create the system of family regulation that sets up poor parents, poor families to fail? How can we have a system in which one of every third kid will be the subject of a child welfare investigation? This has a history, which I'm going to be talking about today. But just to kind of give you the main points, I'm going to argue today that three main policy decisions have shaped our current child welfare crisis. First, the decision to focus on the psychological makeup of parents and why they abuse kids, and not focusing on the societal risk of harm to kids. Second, an active, ongoing attempt to divorce discussions of child maltreatment from issues of economic inequality and racism. And finally, the decision to focus on reporting of suspected child abuse as a primary and sometimes the only method to ensure child safety. I'm going to argue that these decisions were not inevitable or necessary, and were not even based on the available evidence at the time. In fact, they were the result of political expedience rather than what would actually be good for kids. This history is important, not just because I'm a history professor, so I love talking about history. I mean, of course it is, but it also, it teaches us how did we end up with the policies we have. But it also helps free us from certain preconceptions and think about how we could envision a system that's different, that supports rather than investigates families and ensures all children can thrive. So I'm going to touch a little bit on the history of child abuse as a medical concept. Children have been hurt physically, emotionally, and sexually. Unfortunately, they've been hurt in their homes, throughout history. But child abuse is a relatively new term. In the late 1900s and early 20th century, this was described as a form of cruelty, similar to cruelty to animals and other societies that were designed to be protected. Jumping forward in the kind of quickest history of ever, the 1960s saw the rise of a new medical category, and that was the battered child, based on a seminal publication by pediatrician Henry Kemp in 1962. You see here. Kemp and his colleagues surveyed American hospitals nationwide, as well as local district attorneys, to collect information about children physically hurt by their caregivers. They described a new syndrome, the battered child syndrome. The authors suggested that the abuse was related to some defect of character that allowed parents to act on their aggressive impulses. And you can see some of the verbiage here of how these parents who are abusing were described. But it's important to remember that this is kind of the first description of child abuse as a medical concept. And from the very beginning, it was steeped in psychological terminology. Following Kemp's 1962 publication and the public interest that ensued, an explosion of child abuse literature happened. As physicians viewed child abuse as a medical problem, they readily adopted medicalized theories to make sense of what seems to be inexplicable the deliberate injury of innocent children. In the mid to late 1960s, numerous academic articles suggested psychological mechanisms to explain why adults hurt children and what forms of psychological therapy could cure them from this problem. The popular press also embraced these descriptions of child abusers as being mentally ill, sensationalizing a topic that was of great interest at the time. By adopting medicalized explanations for child abuse, physicians were able to maintain their jurisdiction over a complex social problem. It also helped to depoliticize what is actually a political problem, the treatment of poor families. But this focus didn't actually match the existing evidence. In 1970, no, that's not the right one. There it is. In 1970, Brandeis sociologist David Gill, who recently passed away, published his book, Violence Against Children, a monograph on child abuse in the United States. It was funded by the Children's Bureau. And it was like a massive survey looking at reports of child abuse from 1967 and 1968 to analyze the scope and risk factors for child abuse. And Gill's work uncovered significant racial and socioeconomic differences in the incidence of child abuse. He argued that there was an increased incidence of physical abuse, and in particular, serious injuries to children in poor families and in minority communities. He suggested that, I'm going to quote, life in poverty generates stressful experiences which are likely to become precipitating factors for child abuse, end of quote. So poverty leads to these unique stressors that cause individuals to have abusive behavior. And these are disadvantaged populations, Gill explains, there are fewer alternatives and escapes to deal with aggressive impulses. The links between poverty and physical abuse of children, he said, should convince people that addressing poverty was an important part of addressing child abuse. And this is a slide from the first pages of his book, which is really prescient. And he asks, why do we care so much about violent abuse in the home, which of course is terrible, but also relatively rare, but not thinking about the abuse that society is wreaking on the people who are disadvantaged, poor, marginalized, experience racism, and so on. Kind of why do we just care about physical abuse and we don't care about the systems that are allowing this? And then he has, in the second page you see there, this examination of the widespread, intensive public and personal interest in physical abuse of children, and this idea of the sickness as the cause, kind of that something is wrong with your brain, that's why you're abusing children, suggests that they provide relief for the conscience of society as a whole and the conscience for many individual parents. So instead of indicting American society for failing parents and children, we're calling out a few handful of people who are crazy, sick, psychologically disturbed, and that's why they're abusing kids. Like Gill, many researchers in the 1970s believed that poverty and racism were risk factors, not just for more surveillance and more reporting, which we all know is true, but also for abuse itself. Parents who struggle with structural inequalities, joblessness, stress, hunger, social isolation, and so on, are more likely to lash out and hurt their children. And we know this. Parenting is hard, and without sufficient support or respite, parents are more likely to snap. Poverty and racism could lead to child abuse, and these needed to be addressed as a way to protect children. At the time, this was not considered a particularly radical view. It seems like a common sense view. And socioeconomic hardship today is still considered a risk factor for child abuse. And I'm sure you guys know this as practitioners, but there are different studies. I'm just going to cite one by colleagues in Penn who found that there's a compelling association between rates of abusive head trauma in infants and the economic effects of a 2008 recession. So we know that anytime there's a downfall in economy, we're going to see more cases of child abuse. But David Gill took it one step further, and he used the term abuse to refer to any hampering of a child's full potential. He argued that there was institutional abuse in as much as schools, social welfare systems, food support systems, and healthcare systems were not doing enough to ensure that kids can thrive. We should think about poverty and addressing poverty as a form of primary prevention of child abuse. And that's kind of the quote on the slide. While many researchers argued for the importance of addressing poverty and social inequities as causal factors in child abuse, their voices were unheeded by politicians and policymakers. So two main approaches are emerging in the 70s. One focused on the perceived psychopathology of individual parents or caregivers. What is wrong with them that they can do something so terrible? And the other on the societal risk factors that make children less safe. But policymakers had a vested interest in adopting the more narrow view of child maltreatment, rather than one that would actually require you to do something about social inequities. Activists also weighed in on this debate. I'm going to talk about one of these activist groups, Parents Anonymous, which was a self-help group founded in 1969 by a young California woman known as Jolly Kay. She was a colorful character who was always in the spotlight. And she said in her histories that she sought a support for her self-described abuse of her daughter. It was modeled after other self-help groups at the time. You can imagine, like Alcoholics Anonymous and Narcotics Anonymous that were both already active. And Parents Anonymous was designed to give support to parents who had abused or were concerned they might abuse their kids. But their demographics did not reflect what was known about child abuse at the time. It was primarily a bunch of white middle-class women who did not work, who did not actually abuse their kids, but were worried that they might. Again, parenting is hard. That's a theme that we're going to hear about. But also the theme that they were most concerned about in their homes, based on the surveys of their organization, which I examined, was that they might emotionally or socially or verbally abuse their kids, so not physically harm them. Initially a small local group, Parents Anonymous positioned itself as a powerful player in the field of child abuse policy, even though, as I say, it doesn't actually reflect what we know about child abuse. In an era when the media is particularly interested in the human face of child abuse, Parents Anonymous lent itself well to media coverage, and Jolly sought and received intense media coverage and all kind of exposés. The profile in Women's Day attracted a lot of work to the work of Parents Anonymous. In the early 1970s, Minnesota Democrat Senator Walter Mondale, working with colleagues, developed legislation to authorize funds for child abuse and prevention. This would become, I think, what you probably all are familiar with, CAPTA, the Child Abuse and Prevention Treatment Act, that was signed by Nixon in early 1974 and has enjoyed decades of bipartisan support. And one of the main reasons that CAPTA was so successful, that a Minnesota Democrat can pass a bill that Nixon is going to sign off, a well-known veto-prone president, was that it intentionally circumvented discussions of race and class on purpose to make Nixon essentially not be able to veto it, because as one politician said at the time, even Nixon doesn't like child abuse. So while research in the 1960s and 70s found that child abuse was more common in low-income families, Mondale actively pushed an agenda trying to show that child abuse is an equal opportunity offender. And this tension was abundantly evident in the 1973 hearings. So, for instance, the same David Gill testified on the higher incidence of child abuse in poor and minority families, saying, that the increased incidence is not just because of overdetection or over-surveillance, but that poverty in itself is a risk factor for child harm. And Mondale pushed back, pointedly asking, I'm going to quote now, would you not say that the incidence of child abuse is found as well in the families of middle-class parents? Okay, so first of all, it's not how incidence works, right? Yeah, I mean, it's a measure. It's not that there's an incidence. But of course, what's Gill going to say? He's going to concede that, of course, child abuse can also happen in middle-class families. His point was that it happens more often in poor families because poverty is a risk factor. To this, Mondale quickly adds, but this is not a poverty problem. This is a national problem. And a quote, making his agenda very, very clear. Parents Anonymous fit easily into this agenda, touted as the most powerful testimony giving at CAPTA hearings, broadcast into people's living rooms on national TV. Jolly Kay was a young white woman, articulate and easy to identify with. Her testimony was broadcast everywhere, and she was like this narrative of a sinner who had repented. She and the other abusers were, quote, the monsters who had hurt their children. She cited her own experience as an abused child and added that the daughter she abused, quote, reflected her negative self, end of quote. Mondale asked, is this what psychologists call when you, quote, hate something you sense in yourself, end of quote. Jolly agreed. It was the body of the child, but your own identity you were hurting. She asked pointedly, was hurting your child, quote, homicide or extended suicide? All right, so this rubbish pop psychology resonated deeply at the time. Some dissenters warned that medicalizing and psychologizing child abuse is not a great idea, but these were the minority. It is simpler to believe that only seriously disturbed people can do something as seriously disturbing as hurting children. And we see this all the time today. We psychologize all the problems we can't make sense of. So accordingly, interventions to fix parents were seen as key to preventing abuse. With the passage of CAPTA, funds were made available to support different child abuse interventions. Many of these newly funded programs using federal money were focusing on parental psychology. And while there's not a lot of good data to say how these programs worked, I'm going to go on a limb here and say most of them were not particularly effective. I reviewed many of the reports that they submitted afterwards, and not much to that. With Mondale's support, as you can see in this archival letter, Parents Anonymous went on to apply for newly available federal grant funding, which they received. and went on to develop a network of self-help chapters throughout the country. This never was very well attended. There were about 3 or 4 people in each chapter. One of those people was a paid Parents Anonymous employee. I did review the reports. There's not much to this intervention, but it did have a lot of funding. And I do write more about this and kind of concerns about misuse of funds allegations in my book. I'm not going to focus on that now. But my point is talking about Parents Anonymous, that this is a group of middle-class white women who work to expand the definition of child abuse to include emotional abuse, emotional neglect, verbal abuse, and work to actively discount the role of poverty and discrimination, and instead to enshrine this view of child abuse as an issue of personal responsibility stemming from deep psychological roots. It was widely influential, well-known to elected policy officials and policymakers, and helped create this focus on individual psychology rather than societal risk factors for abuse. So I'm just going to put a pin in this moment and remind us all that the choice to ignore risk factors about poverty and racism is exactly that. It's a choice. And that's kind of presenting child abuse as universal, equal opportunity, and an intrapsychic problem is a political choice influenced by activists and politicians who have their own unique agenda. And it was not inevitable. In fact, in the 70s, most child welfare experts, regardless of their own political leanings, agreed that poverty was an important risk factor at the heart of child abuse and neglect, and offered different ideas how we could mitigate that. But focusing on poverty, I'm going to shock you all, was never accepted as a mainstream policy. One reason was a reasonable kind of concern that if you link poverty to child abuse, it might pathologize poor parents, and it lead people to think that poor parents are worse parents rather than that their social situation is detrimental to child rearing. Also, anti-poverty measures were distinctly unpopular in the mid-70s, even though child welfare advocates repeatedly argued that addressing poverty was a crucial step in protecting children. And of course, focusing on intrapsychic problems seems to be kind of cheap and easy. Fixing poverty requires a big structural change. But what could an intervention for parents look like? And what can we learn from this history? I'll tell you a little bit about a program that was developed by pediatrician Vincent Fontana at the Newark Foundling Hospital. Fontana was a well-known physician. He had cared for President Eisenhower. He was a medical director of the Foundling Hospital. And he long argued that physicians should pay attention to the social risks for child maltreatment. He wrote a letter to the New England saying, it is a fallacy to think that abuse was a result of mentally ill parents. Yet, child abuse was, I'm going to quote, inextricably linked with unbearable stress, with impossible living conditions, with material or spiritual poverty, alcoholism, assaults, robberies, murders, and the other ills in the midst of which we live and for which we must find massive healing. Fontana developed a demonstration program that provided residential care to at-risk mother-infant dyads. And this was in many ways a psych-intense program. They housed 35 dyads, each time in a private room, and they received intensive psychotherapy, daily parenting classes, and home ec. They were, the young mothers were taught how to go get grocery shopping, how to cook, and how to prepare meals. And they were discharged after 3 to 4 months and reevaluated in the years following intervention. And Fontana and his colleagues found that actually these moms did great. Most of them were able to avoid any separation between mother and child. Many found new housing, employment, and their kids seemed to be thriving. But they were perplexed because they did all the psychodynamic evaluations, and actually it turns out nothing changed. Despite all this psychodynamic intervention, they didn't really change the psychological or makeup of these people. What they found was offering material supports in terms of respite and housing and basic kind of supports for parents is what actually helps them, rather than trying to change or fix who they are. And indeed, after this experimental program for mothers and kids showed what actually is useful, Fontana went on to open a crisis nursery that offers respite care for struggling parents, which is still open today. Fontana's approach is primarily a story of what could have been. Fontana was a vocal advocate and a well-respected child abuse expert. And in New York, here you see him with kind of at the White House, and here you see him with Sophia Loren. And in New York City, he was a little bit of a semi-celebrity as far as, pediatricians who do child abuse might be. But his model was never widely adopted. While attempts to support families and address poverty were underfunded and quietly ignored, the 1970s saw a growing emphasis on one single aspect of child maltreatment policy, and that was reporting of suspicions of abuse. And this policy begins in the 1960s and hastened considerably in the 70s. The 1974 CAPTA emphasized mandatory reporting and set the federal standards. States opened hotlines, and with significant public awareness campaigns, reports start pouring in. These reports are primarily about struggling families, poverty, hunger, addiction, inadequate supervision. Yet, in most states, there was no appropriation of money to fix all the things that are being reported. Only one state, Illinois, passed budget appropriation with its first reporting laws. The remainder of the states seem to have expected more reporting to require no additional funds. At each juncture, policymakers work to further expand reporting requirements and to increase penalties for non-reporting. The harms, primarily to poor families and families of colors, could be easily foreseen and anticipated. So when you talk about kind of unintended consequences, you should be thinking about maybe unintended, but could they have been foreseen? And these downstream harms were clearly visible to politicians, including to Walter Mondale, who, as I just mentioned, was kind of a champion for CAPTA. I'm just going to tell you one story about this. When a government agency was working to further expand mandatory reporting, and in particular to expand reporting of neglect, Mondale noted, I'm going to quote now, that the government had a responsibility to safeguard families, particularly those who are poor and minority groups, from being enveloped in a system which may label them as criminals or deviants, end of quote, and which lack resources to provide necessary service. Mondale added that if that government agency went forward with a model legislation, Mondale would, quote, and you can see this up here, personally write to other state legislators and recommend that it not be adopted, because he could see what would happen if you expanded neglect even more. So ultimately, this model legislation was quietly dropped, thanks to the objections of Mondale and others. But in the following decades, requirements for reporting have been consistently broadened, expanded, more penalties, more definitions, leading to the same clearly foreseeable outcomes that Mondale had mapped out. In fact, in many states, reports of child abuse and maltreatment increased at precisely the same time that these states were decreasing funding for state and local services. Families often derive no benefit, no material benefit from a report about hunger or homelessness. And this is not just me saying this, that I have some kind of hippy-dippy approach to fixing things. In the words of the 1990 report of the United States Advisory Board on Child Abuse and Neglect, I'm going to quote now, it was far easier to pick up one's phone to report one's neighbor than it was to pick up the phone and reach out to offer and provide help. And this focus on reporting, a singular focus on reporting, has real and devastating impact. As more children are being reported to child welfare agencies, increasing number of kids are being removed from their home. In 1962, 272,000 children were in foster care in the United States at a rate of 3.9 per thousand. A decade later, the number is almost 320 with a rate of 4.4 per thousand. In 1977, an estimated 500,000 kids are in foster care. These children are disproportionately from low-income families and are children of color, disproportionately. So with these rates of child placement and out-of-home care, it was all but inevitable that some kids are being placed in dangerous situations. Concern about child abuse in foster care or institutions begins garnering more attention. Foster care is also quite expensive. Throughout the 1970s, the cost of foster care rose, and the cost was increasingly being borne by state and federal governments. Between fiscal years 1971 and 1979, the total state and federal expenditures on AFDC foster care increased from 70 million to nearly 400 million. Suddenly, policymakers were paying attention. We can see this in the hearings preceding the 1980 passage of the Adoption Assistance and Child Welfare Act. Numerous witnesses deplored what they termed unnecessary removal of children from their homes, which could have been prevented with services. Adequate services at the front end, suggested the director of California's Department of Social Services, would prevent unnecessary removal of kids from their homes. The Child Welfare League of America, disability advocates, and other witnesses agreed. The American Academy of Pediatrics noted that of the 500,000 kids in foster care, many did not belong there, and committed the attempt to shift financial incentives away from perpetuating unnecessary foster care placements to trying to keep families together. Many witnesses also highlighted how more reporting leads to more removal. In 1980, President Carter signs ACWA, the Adoption Assistance and Child Welfare Act, outlining two main methods to reduce the number of kids in foster care. And these are obvious, right? You want less kids in foster care, you try to prevent out the front end, removing kids to put them in foster care, or increase the back end, have increasing adoption. And that's kind of the name of this act and the main focus, focusing on removing less kids and adopting those who have been in foster care for a long time. The ACWA did not address whether increased reporting contributed to increased child removal. And there was no political will to argue that not all undesirable home situations, including extreme poverty and deprivation, are the same thing as abuse or neglect. Still, the ACWA advocated for more family preservation services to reduce unnecessary removal. But ACWA could not have come at a less opportune time, 1980. The Reagan administration early on made abundantly clear its plans to reduce funding for child welfare services and essentially any other social services. And that's indeed what happens. The Reagan administration limited the appropriation for Title 4B money, which is what was supposed to pay for family preservation. In contrast, the 4E funds, which are what pays for foster care, continued to rise from levels that were already twice that of 4B. But this is not just a story about funding. I mean, yes, there was not enough funding for child preservation. That is a problem. But there was also no guidance on how to do family preservation. And what were these family preservation programs like? So for the most part, these interventions primarily focused on offering intensive short-term therapy, casework, and parenting education. And this is a review of 36 programs that note that actually intensive casework does not reduce out-of-home placement. And why is this? Well, all these interventions were designed to fix parents, to fix what is psychologically wrong with parents and focus on that, rather than addressing the poverty and material challenges these parents face. And as such, these interventions were destined to fail. But not only did they fail, they set the stage to argue that family preservation was useless or even dangerous. It had been tried and failed, and this has far-reaching implications. Unfortunately, this underfunded and ineffective attempt for family preservation, focusing on fixing what's wrong with these parents, is emerging as the legacy of ACWA. And child welfare experts and policymakers view the deficiency of this family preservation program as evidence, again, that family preservation tried and failed. And this sets the stage for the 1997 Adoption and Safe Families Act, which is my new book project. So I can, in the Q&A, I can talk about that endlessly, but I'm just going to gesture towards it now. So the Adoption and Safe Families Act, which is the act that governs today child welfare, ASFA, reduces the requirements for family preservation attempts and focusing instead of what is perceived to be child safety. Adoption is elevated as a primary way to increase or enhance safety and permanence through the termination of parental rights. And ASFA greatly hastened the timeline for termination of parental rights, even in cases when there was no allegation of abuse. And I think many of you, I saw a whole bunch of social workers walk in earlier. I think many of you are familiar with the 15 out of the past 22 months rule. If your child has been out of home placement, even if there is no allegations of abuse, if a parent is serving a sentence in the country that incarcerates the most people in the world. So even if the child is out of home for reasons that are not abuse, that the clock is ticking and it can culminate in termination of parental rights. If fixing parents is futile, the next logical step is simply removing children and providing children with new parents via adoption. This is a culmination of approach that located the cause of abuse or neglect within an individual parent's psychological makeup and not as a reflection of the societal challenges a family might face. And this is an ongoing challenge at ASFA, and especially now in the COVID times when a lot of people had timelines that they couldn't meet because there was actually no services or no classes to take, or so on. So ASFA is in my mind a culmination of this view that, well, we've tried to fix parents, we fail, so now we're going to give kids new parents. Or a approach to poverty in which our solution for poverty is to remove poor children from poor families and place them in middle-class families and provide those middle-class families with subsidies to raise these children. There must be a more straightforward way to do things. So what can we learn from all of this? Why should we care about this child welfare and poverty, and why is it important today? So in the remaining time I have, I'm going to try to map out what I think we can learn from this episode, although I recognize that I've only shown you a little bit of my historical evidence and my data, but much of it is grounded in the archival work I've done. So the first point I want to emphasize is that while our primary response to children and families at risk is one of reporting and investigation, it doesn't have to be that way. In fact, when the US adopted a policy centering reporting, it was in the absence of any data to support that. Current evidence seems to suggest that there is a limit to the benefit of mandatory reporting and that more reporting isn't actually better. And then there's studies that compare universal reporting states versus non-universal reporting states. And it finds that kids are not safer and they don't have better outcomes in states that have more reporting. In fact, a reporting often comes in the place of providing kids with what they need, which is referral to services, food, and shelter. As early in 1973, a child welfare agency in New York made that really obvious observation that investigations in themselves are not actually useful to families unless they lead to more services. Unfortunately, not much has changed today. We're 50 years later. We know that today, the majority of investigations of alleged child abuse and neglect, they don't result in the provision of new services. Still, research shows that many clinicians file reports because they want to get kids access to services, or mistakenly believing that a report will result in that. So a kid has bad teeth, you call CPS for neglect. You hope the kid is going to get a dentist. The kid is going to get an investigation, but it's not going to result in dental care. So there's often a disconnect between what clinicians think that reporting can do and what reporting actually does. And this is what in 1983, pediatrician and child expert Dr. Eli Neuberger, and he works in Boston, he still gives expert testimonies in his mid-80s. He termed this the abusification of child welfare. So instead of thinking about child welfare, we're thinking about everything through the lens of abuse. And in order to get child welfare services for children, we have to allege abuse. So we want kids to have a coat. So we call mom in for neglect for letting the kid to go to school without a coat. What the kid actually needs a coat. But we have this roundabout system in which we don't have a good way to get services without an investigation first. And some states are actually pioneering now ways to not do that, to have a direct line for services that doesn't go through this abusification process. But why was reporting touted as a primary policy to keep kids safe? Mainly because policymakers thought that they could get away with increased reporting without increasing funding, a form of no-cost political theater designed to appear tough on child abuse, without in fact addressing the risk factors, the societal risk factors of abuse. Recent data from New York City, for instance, has shown that despite a reduction in reports over the pandemic, there's no evidence to support the idea that kids were less safe, or that there was a crisis of undetected harm to children, which is one of the reasons that people were worried about, schools being closed and kids are being abused in their home and a crisis of abuse. That did not materialize. Not that kids weren't being abused, but that reporting and surveillance was not an effective way to keep them safe. So it seems that we've erected a complex system of surveillance, reporting, and investigation, but does not actually keep kids safer. Furthermore, as sociologist Kelly Fong and other researchers have shown, reporting makes parents less likely to engage in valuable services in their communities and their schools, depriving kids of resources that could help them thrive. And we know this in so many fields. In a big study from Manitoba showed that moms that had an interaction with CPS for drug use during their first pregnancy are going to go without prenatal services for their second pregnancy to not have that outcome. So we're deterring people from actually getting services that were helpful in a system that really provides mainly surveillance and not services. Reporting and investigation causes real harm and trauma to children and families, and disproportionately so to poor families. This is a primary political choice forged in the 1970s and onwards. So recognizing that lets us say, we can and should make different choices as we move forward to support kids. And the second point I'd like to emphasize is that it was a distinct choice to portray child maltreatment as a result of a faulty psyche, rather than a symptom of societal dysfunction. There are many ways in which poverty and experiences of racial and ethnic discrimination overlap with child protection services. First, poor families are already disproportionately scrutinized and surveyed through other agencies of the state and are more likely to come to the attention of child welfare agencies. Second, poverty is often conflated with neglect. A kid who is lacking basic needs is taken to be evidence of poor parenting rather than as evidence of society that is failing to protect its most vulnerable citizens. And we also know that extreme stress, crowding, isolation, and deprivation are actual risk factors for real harm to kids. To ensure that children and families can thrive and reach their full potential, we must avail families of the resources to do so. And addressing poverty as a primary support to parenting is, as Gill said almost 50 years ago, a form of primary intervention. So what could that look like? In the United States, which has one of the highest rates of child poverty, with over 10 million kids defined as poor, these supports could and should take the form of universal child care, child tax credits, child allowances, access to Medicaid, and housing supports. Furthermore, poverty is generational. And when a child is temporarily removed from their parents, they should be preferentially placed with a family member. And if that family member is also poor, which is what happens usually, poverty should be addressed rather than taking this kid and placing outside the community. In the heartbreaking case of Mical Raz, who was shot by the police outside her foster home, Macal's mourning grandmother, Miss Janine Hammonds, told the New York Times that her housing insecurity was the reason that she, grandma, was not allowed to care for her granddaughter. I'm just going to quote, "They could have just given me what they give one foster parent, and then I could have gotten housing, taken care of the kids, and done what I needed to do." So Mrs. Hammond, she was living in a hotel at the time. And that was why Mical couldn't be placed with her. And finally, we should move away from the framework that pathologizes and medicalizes parents who have been accused of hurting or neglecting their kids. While there might be a small subset of truly disturbed parents who do need psychiatric help, we know that the vast majority of reports for kids to Child Protective Services do not involve physical harm to children, and they're not caused by parental mental illness or bad parenting or parental pathology. In fact, the vast majority, like over 80%, plus it depends on how you calculate, most of these reports are related to perceived neglect, too often confused with poverty, and this includes inadequate housing, inadequate medical care, and unsafe housing. Parental substance abuse is another reason for coercive intervention into families. We know that this is a number one reason for removal of children from their homes and placement in out-of-home care, is parental substance use. And that's really complex because some substances are actually legal in many states, and some parental substance use during pregnancy is not monitored, and some is criminalized. And this criminalization has clear racial and socioeconomic biases about who we test and what substances we allow, and what substances, which are perhaps less harmful, result in an investigation. And of course, this leads to all kind of questions such as autonomy and dignity, when some mothers who come in to deliver pregnant people are more likely to be urine tested and reported than others. And in some cases, mothers are even faulted for when they use prescribed substances. So a doctor can prescribe a woman medication-assisted treatment for their substance abuse. And in some states, the medication-assisted treatment would be enough to trigger a child abuse investigation into this mother. And this idea that we can psychologize or psychiatrize complex problems such as this and kind of think about what is wrong with individual parent and send them for services that are supposed to fix them has a very pernicious effect on society. And I was just reading, yesterday about how in New York City now we're thinking about psychiatric intervention, coercive psychiatric intervention as a solution for a crisis of homelessness. And I think most psychiatrists do not want this kind of expansion of their discipline. And in so many ways, psychiatry has been called on to do things that psychiatry cannot do or is not supposed to do. And instead of kind of shifting the discourse, instead of these pressing social problems to becoming a psychiatric problem. Now, if we had any fantasy that the child protection system is divorced from politics and culture wars, which you probably don't have that fantasy, but even if we did, then these fantasies should have all been laid to rest with the recent stories coming out from Texas, which include recent measures to criminalize the very existence and care of trans children in Texas, as this demonstrates how child abuse allegations and investigations are used as a cudgel to punish and criminalize certain families. This is one of my pieces I wrote in March when that came out. In the meantime, in Florida, trans care is completely banned. And so these are kind of many ways in which child protection is a way to enact harmful policies that not only don't protect children, but actually hurt children and their families. And this, of course, is not just Texas. This is an article from late 2021, and this is coming. I mean, I'm sure some of you are aware that when Tucker Carlson highlighted the work being done at Golsano, then Golsano became the target for harassment and so on. So fixing parents by offering them parenting classes, anger management classes, psychotherapy, other kinds of intensive therapy has not actually been proven beneficial. And it's based on the faulty assumption that something is wrong psychiatrically or psychologically, or something is wrong with struggling and poor families. Parents are often coerced to participate, to complete trainings and certification by threat of further coercive intervention. So if you don't complete these trainings on time for this hearing, your parental rights may be terminated. But what if we offered services that were actually things parents wanted, that were valuable to parents, that parents clamored to participate in rather than being forced to? What if we tried to offer high quality childcare for kids, like Dr. Fontana showed us? What if we offered affordable housing or respite care? Rather than trying to fix parents, we should focus on fixing poverty and fixing the many risk factors that we already know and have identified since the 70s as being harmful to kids and families. And how can we ensure that we can lift up families to thrive and grow without coercive interventions? How many more anger management classes do parents need to take to have a diploma that says the right date within the right time frame to bring that back to court? Because if it expires, if it's not within the right term, they have to take it again. It's often on the other side of town. They have to take 3 buses. But these are not the services that they actually need, which is often treatment for substance use, it's like housing. It's why don't we listen to what people are asking and ask them what are your needs and try to meet them rather than some kind of fantasy that we project about what is wrong with these people, and then we try to fix that. Our current child welfare system, which disproportionately targets and separates poor families, is not inevitable. Looking back at history to learn how child welfare came to be the way it came to be offers us a vision of what an alternative might be, recognizing that these political choices have shaped and created the system that we have, helps us think about how we could make different choices and advocate for different policies that would allow a system that each child can thrive. Thank you.
Thank you, Dr. Raz, for a truly provocative and very, very important topic, covered in a very expansive way, and in a way that I think probably has enlightened all of us. So I'm very curious for folks in the room, what questions you might have for Dr. Raz, and I'll be monitoring as well online in the chat in case there are attendees online who have questions as well. She did call out the discipline of social work. I wouldn't do that. But no, I'm just kidding.
No,
I would do that.
Commended the social workers.
I mean, while people are thinking a little bit about what your talk today stimulated for them, some of what occurs to me is that, while your talk didn't go into this, I imagine we could swap out child protective reporting, child welfare for many other things that all of us are handling in our offices all the time. So the primary substance use, the primary mental illness, that so many of those things really are derivative of poverty and marginalization and racism, which I'm glad to be bringing more light to through this talk and hopefully through other avenues as well. I won't ask for you to give an exhaustive review of the evidence of that, but it's very good for us to be thoughtful about it. I'm going to check online as well and see if we have any Q&As in here.
I think it's really hard for psychiatrists and people in the mental health fields because you're being called on to solve all these problems that you cannot solve, but you want to solve. And it's like, okay, it's not a gun problem, it's a mental health problem. And you're like, well, we do need mental health, but that's perhaps not the solution for this big societal issue that we're facing. And how do you contribute to this conversation without being another force for medicalizing and psychologizing, shifting the focus away from big societal problems while still advocating for, yes, mental health is really important, but is mental health really going to solve all our problems of homelessness and gun violence and so on? What can mental health do and what can it not do? And I think these are really challenging conversations. And often kind of in my previous book on what's wrong with the poor, there's a big focus on diagnosing people who are poor as suffering from depression. And of course, you don't want to underdiagnose people with depression just because they're poor, but also there's the risk of using diagnosis to fix problems that are actually structural and systemic. And what people need is housing and access. And I think there's so many fields, as you say, that it's the same kind of pattern. that medicalizing often is like a safe substitute for talking about problems that are political, contested, and nobody really has the political will to address meaningfully.
Absolutely. And clearly major depression and poverty are not mutually exclusive. And it sounds like maybe the biggest issue is in how we perceive the causal relationship and then derive treatment suggestions or care plans associated. So because you invited the question to yourself, I will invite you to try to answer it on behalf of our department, which is, this is a department of psychiatry. The way that we engage with most of the patients and families with whom we spend our days really is through that very traditional mental health referral, or sometimes from courts or from CPS or other places. If you could recommend one thing for our department to consider by way of action, in addition to providing evidence-based treatment for the major depression, generalized anxiety, PTSD, what would you invite us to do?
Oh, wow. That's such a hard question.
You have to pick just one.
That's really tough. And I have gotten a similar question from pediatricians who say, well, what do I do with the individual kid in front of me who needs something now? And of course, child abuse is real, and some people should be reported and to have intervention. But I think what we should remember, and I think as clinicians, we really, I know I'm certainly trained and steeped in that, to really find out, what's wrong with something, diagnose, and give categories and interventions and try to fix them. And a lot of it is based on the question of, what is wrong? And that's kind of my book, What's Wrong with the Poor, What's Wrong with Certain Groups. And of course, that's part of what we do as doctors. But I think we should also be taking time to ask what is right with the people we're saying in the communities, and what are their sources of strength and resilience. And that while we're asking what is wrong, we should be asking, how can we further uplift the parts that are so right? And what are the systems of support? And I'm sure that in your mental health work, you are relying a lot on the supports in the communities. But I think thinking about that alongside the thinking about medicalization and pathologization that we do in our everyday clinical experience is kind of a meaningful mind shift.
Yes, thank you so much. While I was droning on, there were a number of questions that rolled in, so this is good. The first question is, after working in child welfare, it's notable that there's extreme bias in reporting and gaps in understanding that services are offered to families, whether they're voluntary. They're rarely court ordered. More in-depth education for mandating reporting would be beneficial. Are you advocating to OCFS or other agencies for improved reporting and support?
Sorry. So I think this is really, really interesting. And so I think a couple of questions about that. Like, what does it mean to be voluntary, right? So services are voluntary in as much as they're not court mandated. But often if they're not voluntary in as much as a person can't decline them, because there will be repercussions that could be devastating. And I think there is no voluntary interaction with the coercive agent of state that has the power to take away your kids. And so we should put away voluntary. We should be court mandated and not court mandated, but nothing is actually voluntary. You think about placements of children where voluntary placed. This is always from a position of power and coercion. So I think that we should be training mandated reporters. And I actually have a big commitment to that. I write for pediatricians all the time and try to place articles to think about, what are the unintended consequences of what we're doing with such a knee-jerk thing of, we should report this, and not thinking about the downstream consequences. I think about educating mandatory reporting about bias in reporting, about bias in intervention and removal, but also education about what does your report actually do? So what do you want for a kid? And usually the answer is we actually want services. We want a coat. We want a ride. We want the kid with diabetes to come back in 2 weeks, and mom is not bringing the kid back. And sometimes that really prompts a referral rather than a ride. So I think, education is really, really important. Often the education is the opposite. If you see something, say something, and you'll never be wrong for reporting. But you actually, of course, you should follow the rules of the state you work in and the ethical guidance. But there are actually all the incentives are towards the more reporting for the clinician. You check a box, you move forward. But in fact, there is no accountability for unnecessary reports. And it's such a huge strain and trauma that we should be paying attention to what it does to families who are already struggling, to lose days of work, to have to tell the boss that they can't come in because they have to go. And these have really long lasting downstream effects. In some states, just being accused will land you on the registry, even if you're not substantiated. And then you can never work again as an aide in a daycare or as an aide in a nursing home. And then, that's it. You can't feed your kids. So we should be conscious of all these things. And I absolutely think that education is essential.
I do think this thing about reporting is so crucial. There are a couple of questions that highlight this theme, which really is about based on the history that you shared with us today, and frankly, your last several statements, what recommendations do you have for how we as clinicians should be thinking about reporting? So we definitely have clear structures and rules around which we must report X, Y, and Z kinds of things. And we also know there's tremendous latitude for clinical judgment. So what advice could you give us for how to surf that line?
Well, that's complicated. Of course, you should follow the guidelines of the institution you're working at and the requirements of the state and the licensing boards. That's it. I think a lot of people feel that they have to report because there's a misunderstanding of what the statute requires. And people, if you even think about it, you have to. If you heard from somebody else about a kid who's riding unbuckled, you have to report that family. It's like, no. There are clear situations in which you have to report, but there's others in which you have a lot of room for clinical judgment. So if you are not actually thinking that abuse is happening, you don't actually have to report. But people say, I don't think it's abuse, but I'm going to report anyway because that's what the statute requires. I was like, that's not what it actually requires. And you are allowed as a clinician, as somebody with training and clinical experience to use that and to rely on that. Usually, and there's a really good article by Clara Pressler with Family Defenders in Bronx. It's called the mutual deference. So the doctors report to the CPS because they think, I'm a doctor, I don't know, CPS will sort it out. And CPS says, well, the doctor said, so that must be right. And nobody's actually doing the work of investigating because it's a mutual deference. Each one thinks of what the other one said. But for you as clinicians, when you say, I'm not going to look into it, I'm going to just let CPS, you're substituting your judgment, your clinical judgment, your professionalism with that of somebody who has maybe an undergraduate degree, working maybe for $11 an hour, maybe in New York it's 15 now, and having a caseload that's huge. And they don't have the ability to do the things you want them to be doing. And it becomes a frustrating experience for everybody. So I think being cognizant of what is that you want to achieve with that report and see if there's another way to achieve that, to make sure kid comes back to the appointment, make sure kid has a coat, all the things that you truly deeply care for these children and you want to make sure that they have what they need. What is a way to do that without abusifying their needs to use child abuse as a way to get that services?
Yes, another recommendation for the both and minding the local ordinance and rules, but also being clear about what else is on the table. There is a question here asking if you could share your knowledge, please, about any effective local family preservation efforts.
The child tax credit. Sorry, that's a very short answer. But generally, a lot of family preservation programs, to do them well, they require a huge amount of resources and the system is actually not really set up for that. But things that actually preserve families and we know are housing, support, the child tax credit has been very helpful in kind of reducing needs for families. So I think, again, a mind shift from thinking, how can we fix these families, family preservation interventions that are focusing on what's wrong with people to thinking about what do they need. So those are the kind of interventions that are actually useful. And there's a host of downstream effects of kind of providing families with money or providing family with access. So in my mind, family preservation looks like Medicaid expansion, looks like child tax credit, looks like resources for families to thrive.
Just going to do a quick scan of the room. Otherwise, yes, Tara. Really sorry, you have to use this magic stick.
Shouty enough. I super appreciate that. And from part of my clinical work on the inpatient child and adolescent psychiatry unit, I'm deeply resonating with some of the things that you're saying. I am curious, in following up as we're thinking about reporting and thinking about uncertainties of if abuse is happening. And I personally have encountered a lot of patients who report something to me that is specifically concerning for abuse. I have received feedback from teachers, trainers, and supervisors who have suggested that we can call and run a case by the reporting service in an anonymous way without giving those details. And then that individual can let us know if this is an appropriate report or not. I am full of suspicion for that process and curious if you have reflections or recommendations about how to proceed in recognition that this is a system that reinforces reporting.
Oh, that's tough. So I don't know about the running of the case. I do think that if we're not actually reporting, they're not taking the actual details, that there's not a risk that that's actually going to be a report that you didn't mean to make. But if you don't provide the details, but I think in general, the bias is towards more reporting. So if you ask them, should I report? I mean, have they ever said you don't need to report? I think that would be unlikely. And of course, if you think a child is in imminent harm, I don't think you have any doubt. You never have doubt when the case is that the kid is in imminent harm. It's a gray area, is that do I need to report? And that's where we also kind of use our clinical judgment and spend time thinking about it. And of course, you guys see the toughest cases. This is, you are not reporting people for not having a coach. I know that. That's the people who are, this is usually the school systems that are coming. That's the biggest bulk of the educational reports who are trying. So how to navigate that is tough, and obviously you should follow the institutional and local guidance. But I think is there other interventions that would resolve my concern that don't involve resulting in a coercive investigation would be kind of what I'd be asking myself.
Well, Dr. Raz, thank you so much on behalf of all of us here in the room and the 102 people who joined in online. Thank you so much for joining us today for this very thought-provoking talk. And happy birthday to you. We should really say happy birthday to your mother. She did all the hard work. But thank you so much. We're so lucky to have you as a local resource, and thank you to everybody for coming.
Thank you very much.